So welcome everyone. Thank you for joining us for the second day of our Exercise Oncology Education Week. I'm very happy to introduce my colleague and friend, Dr. Daniel Santa Mina, to present this evening on Prehabilitation in Exercise Oncology, Role of the Qualified Exercise Professional. So Dr. Santa Mina is an associate professor at the University of Toronto in the Faculty of Kinesiology and Physical Education. He also holds a cross appointment to the Faculty of Medicine in the Department of Surgery. He's a clinician investigator at the Toronto General Hospital Research Institute within the Department of Anesthesia and Pain Management. Dr. Santa Mina completed his PhD in Kinesiology and Health Sciences at York University and did a postdoctoral fellowship in the Department of Surgical Oncology, Division of Urology at the Princess Margaret Cancer Centre. Daniel comes with a wealth of experience. He's also a CSEPT clinical exercise physiologist with advanced training in exercise oncology. Daniel himself has led many training courses and pieces on exercise oncology, so he absolutely knows his stuff as a registered kinesiologist. His research focuses on exercise oncology and the effects of preoperative conditioning, known as prehabilitation. So we have an expert here that's going to share some of his knowledge with prehabilitation and the role really of the qualified exercise professional. Daniel and I have worked together for years, and Daniel is part of our national team for the Excel project, which some of you may have heard of yesterday when we did our introductions, but it is our exercise oncology implementation trial for across Canada, really reaching rural and underserved populations. Daniel's the director of the Applied Clinical Exercise, or ACE laboratory at the University of Toronto, and co-director of the Prehabilitation program at the University Health Network. Daniel is an avid basketball player, Raptors fan, hopefully going to have a good season to enjoy that, and he continues to play himself regularly. So please join me in welcoming Dr. Daniel Santa Mina, presenting on prehabilitation in exercise oncology.
Amazing. Thank you so much for that generous introduction. And thank you to the whole team, Dr. Nicole Coulous's Reed Lab and the entire group that has put on this fantastic event. So I'm really pleased to be here today and talking about this idea, this concept, this state of practice that I really love, that is prehabilitation. And in particular, in an area that I've been working a long time in, and that is oncology. So I'll jump right into it. In terms of what I'll be discussing today, I'll give just a very brief overview of what prehabilitation is. And again, I will focus it probably specifically to cancer, given the audience today. And because we really want to discuss what the, implications are related to the evidence of prehabilitation for qualified exercise professionals, I really want to dive in to some of the practice-related elements of prehab for QEPs. I'll finish off by providing some resources and some guidance that are recently published, and hopefully jump into some discussion with you all in case you have some additional questions. Okay, so I'll jump right into a quote that I like to use to start off many of these talks. And this is out of the BMJ in 2017 by Winterblith and Morthy. And the authors describe major surgery as being like a marathon, or running a marathon, and both require surgery. I think that's really important to keep in mind, because these are very heavy duty physiologic stressors that challenge our systems in ways that sometimes make it very difficult to recover. We would never jump into a marathon without any training or any preparation, because an injury is likely imminent. Well, similarly, despite as many preparation activities that our healthcare team can go through to make sure that we're safe in the operating room, we have a role in making sure that we're prepared so that we are as healthy as we can be throughout the entire surgical experience. And when we think about exercise and surgery, there actually are a number of physiologic similarities. Sympathetic activation, cortisol, or changes in hormone activity and bioavailability in the system, changes in how our heart works and how we consume and utilize oxygen. All of these occur during exercise, but in a surgical experience, these are also elevated. So when we're thinking about the concept of prehab, the idea here is, can we create a physiologic buffer against the trauma of surgery? And this is the classic image describing prehabilitation by Carly and Zavorsky in 2005. And really, it is the foundation of what we generally consider to be the concept of prehab. And in this gray line, or sorry, this black line, you can see maybe the typical pathway towards surgery, where without much, without doing anything, you kind of carry on towards surgery. You have your surgery, and then there's a typical decrease in your overall functional ability as you go through the trauma of surgery and then the acute convalescent period. And then over time, you recover. And this hash line going right through the middle of the slide here denotes the functional threshold. So for example, after surgery, you're probably going to fall below that functional threshold, for which for a little while, you'll probably need some help doing many things. But with some rehabilitation, you'll bounce back above and carry on, hopefully back to where you were beforehand. Well, the idea behind prehab is that if you, in the preoperative period, exercise and do other health behaviors, hopefully what we can do is create a buffer. And this buffer here, despite the fact that we still decline in a similar way, it results in a lower amount of time spent below the functional threshold and hopefully bouncing back in a similar way, but even higher than you were before surgery. So I think this is a concept that we typically think about when we're talking about prehab, and using the term buffer is quite common. But I think that it's important to understand the evolution of what we now know as this preoperative experience that many patients encounter. And at the time of an understanding of a cancer or knowing that you have to go for surgery, patients often don't necessarily just maintain a level of well-being. In fact, they often decline over that period of time. And that could be for a variety of different reasons. That could be related to progression of the disease. It could be related to the stress associated with a diagnosis and an inability to perhaps work on things that might maintain your health. Or it simply may be due to overall deconditioning associated with other factors, whether it's aging or what have you. So there are a number of reasons that may result in our deconditioning over the preoperative period, which really is the opposite of what we want. And unfortunately, while we have many people who decondition, there are a few still who probably already start off at this, on the precipice of maybe a real challenging scenario where they're already on the functional threshold, and then they drop even further and they're really in a difficult state, and they may never ever return back to a functionally independent state. So we're learning more about the preoperative characteristics and the experience of people. But I think the idea here is that with prehabilitation, you should be able to buffer any of these declines over the preoperative period and hopefully make your recovery much better. So I think within the context of cancer, it's probably worthwhile describing or defining what prehabilitation is. And this definition by Dr. Silver and colleagues probably stands out as being the one that most people follow. And I'll read it here. It's a process on the continuum of care that occurs between the time of cancer diagnosis and the beginning of acute treatment. It includes physical and psychological assessments that establish a baseline functional level, identifies impairments, and provides targeted interventions that improve a person's health to prevent or reduce the incidence and severity of current and future impairments. So I think it's important to appreciate that there are assessments and there are interventions. And then there are likely additional assessments afterwards to see how the intervention went and to see what the overall experience was of the patient over the course of their surgical experience. Now, I'm referring to surgery a lot because that's where a majority of the evidence related to prehabilitation lies. However, there are other possibilities for which prehabilitation may be important. And we know that surgery is not the only treatment for somebody with cancer. And in fact, in any cancer journey, somebody may undergo multiple different types of treatment for which preparing for may be very important. We've recently proposed this idea or this concept of multiphasic prehab. That is, there may be multiple phases for which appropriate preparation for the imminent treatment may be important. And so, for example, we may know that there's a surgical date and prehabilitating over this particular period relating to the surgery is important, but we also may know that a patient may also receive adjuvant chemotherapy or adjuvant radiation therapy for which a different type of prehabilitation may be required. For example, in chemotherapy, the cardiotoxicity associated with those types of treatments may warrant investment into aerobic exercises more so than they would have in the pre-surgical period. So these are just some examples of where prehab may be implemented. And again, to highlight, it may not necessarily be just surgery, although that's where the evidence generally lies. And prehabilitation may not necessarily just occur at one point in time over the course of one's life. Multimodal prehabilitation, I'll get into this multimodal part shortly, likely occurs prior to the initial treatments, but we also know that patients may undergo secondary cancers or recurrent cancers. And again, the cycle starts over. Prehabilitation probably is an important part of the next phase in that person's experience. And so really, what are we talking about when we're discussing prehab? And the word I introduced a few moments ago, this idea of multimodal prehab. Well, it is, as we may suggest by the math here, that 1 + 1 = 3. And the idea here is that by adding all of these components, all of these health interventions, we can derive a synergy that actually is more than simply the sum of its individual parts. And when we're talking about multimodal prehab, here are probably the 5 pillars that we typically think about. Medical optimization, meaning is the patient optimally ready for surgery or whatever treatment they're having based on various medical needs? Is it their medications that need to be changed, deprescribed, or taken up a notch? Are there other underlying conditions that would otherwise increase one's surgical risk? We'll talk a lot about exercise in a moment, but generally speaking, aerobic and resistance exercise, as well as other targeted interventions related to specific tissues that may be affected. And then diet, psychological, and other interventions that support health behaviors or the cessation of adverse health behaviors like smoking or other substance abuse. So when we're talking about prehabilitation, we're really talking about a combined approach at making somebody as absolutely healthy and fit as they possibly can be prior to a pretty significant health stressor. And what does the literature say? Well, I'll talk about the findings in just a moment, but I think it's worthwhile highlighting the growth of prehabilitation research over the last little while. As I mentioned, in 2005, that kind of key paper got things going, but it did take a little while before the uptick really started. But in the last few years, you can see that there's generally several hundred papers per year being published on this concept, and 445 over the last little bit have been specifically pertaining to exercise and cancer. Cancer or oncology in the search fields. So, this is a really rapidly growing area, and again, an area of focus specifically within oncology. So what are the data showing? Well, I've put a few citations on the right side of this slide here. These are recent systematic reviews on prehabilitation in cancer for the most part. And what we're generally finding is that prehabilitation is feasible and it is safe. And I think feasible is very important because we have to think about that timeline that leads up to surgery, which may not necessarily be very long, but it's also during a very stressful time for many people. So it is feasible, it's safe, including high intensity training. I'll talk about that in a little bit, and including older people with cancer who generally may be a little less fit or a bit higher risk for surgical complications. And in terms of the outcomes, pre and post-operative aerobic function are improved, quality of life, length of stay, and surgical complications. And while all of these are very important outcomes to find within the literature, surgical complications has been a key outcome in driving some of the change in practice. And here are a few systematic reviews that highlight the benefit of prehabilitation as it pertains to complication rates. And I won't bore everyone with the forest plots here, but highlight the bottom line, which is that compared to usual care, the odds of having a surgical complication are much lower in those who are prehabbed versus those who are not. And the odds ratio range from about 0.63 to 0.52. So these are pretty big differences between groups and a pretty key clinical outcome. And when we're thinking about potential mechanisms, again, I kind of go back to this idea of physiologic reserve or a buffer. And in terms of physiology, I know many of the attendees on today's session, given the focus on qualified exercise professionals, you'll appreciate VO2 or VO2 peak or VO2 max. And it's actually quite a common preoperative surgical test to make sure that patients are healthy and safe to go to surgery. And when we look at some of the literature pertaining to VO2 as a predictor of perioperative outcomes, we find that many indicate a significant association between VO2 and complication rates. And this is found at VO2 peak, but it's also found at the anaerobic threshold. And this is within a pancreatic surgical group, where we're finding that their survival after pancreatic surgery is better for those who have a higher VO2 anaerobic threshold than those who have a lower VO2 anaerobic threshold. But we also know that the VO2 via the cardiopulmonary exercise test is quite a labor-intensive test from all perspectives, whether you are the team delivering or conducting the CPET, or you are the person on the treadmill going through the challenge. So it's important to consider other mechanisms with which we can derive an understanding of one's functional capacity prior to surgery. And many of you are probably familiar with the 6-minute walk test. And that's actually grown in popularity as a preoperative risk indicator over the last little while, given its relationship with anaerobic threshold, VO2 peak, and its sensitivity to picking up those who are at high likelihood of having a surgical adverse event. In this particular study by the Measurement of Exercise Tolerance for Surgery study, the METS group, led by Brian Cuthbertson and Daminda Wajisandera, they found that the 6-minute walk test does actually have strong predictive capacity as it pertains to 30-day quality of recovery, as well as a 12-month functional recovery. And so I think it's important to consider that not just surgical complications are important to be predicted, but also the overall functional status of patients in the postoperative setting as well. Okay, so I've gone through some of the stats and some of the background evidence to support an argument for prehabilitating a patient. But now I really want to focus on maybe that exercise piece that many of you are very interested in today. So let's talk a little bit about how we might deliver exercise programming. And specifically, we'll start off with who we might deliver exercise and broadly speaking, prehabilitation to. Well, first and foremost, it's important to understand the priority groups that we may want to work with. For a number of surgical programs, they may see thousands of patients per year. And within the community, you may encounter many patients who need surgery. Do all need prehabilitation? Well, I think it's important to consider the resources that any given program or institution have. And generally speaking, resources are likely best utilized if they're allocated towards those who are in the highest need. And so in terms of screening for patients, there are a number of different risk calculators that we consider. The American College of Surgeons basically has a number of potential risks that we can identify prior to surgery. BMI and functional health status I've highlighted here because these are two potentially modifiable risks that we can tackle. And if we know of someone who has an unhealthy body composition or poor functional status, they're probably the ones that we should be working with, given the fact that those are modifiable to some extent. So when we're thinking about who we might, what we might use to screen for the appropriate patient, well, we can think of a variety of different health indicators. Again, BMI is an important one. I've listed some ranges here. And I don't necessarily want you to think of just someone with a very high BMI, but also someone who may be malnourished on the other end, which is a very low BMI. Both are associated with morbidity in the surgical setting. If we're thinking about functional status from a self-report measure, the Duke Activity Status Index is a common measure used that can be used for screening. And again, depending on the literature you go to, a score of 24 or 46 points may be a threshold. Or we go back to good old physical activity volume and our understanding of what is a healthy amount. And generally speaking, if you're under 150 minutes per week of moderate to vigorous aerobic activity, that probably means you're at risk for not ideal surgical outcomes. If you're able to do something a little bit more precise as a screen, and again, as a screening tool, it has to be done to many people, but the 6-minute walk test under 400 meters would suggest increased risk. 5 times sit to stand of greater than 22 seconds would suggest increased risk, as well as fewer than 11 repetitions of the 30-second sit to stand test. Now, while these are some important tests that we can consider as screening methods for the right prehab patient, I think it's also just important to think about those who are frail. And frail is a multidimensional syndrome for which a number of adverse outcomes can emerge across a variety of different treatments. And when, at least as it pertains to surgery, you can see that the rate of complications, mortality, readmission, and reoperation are actually much higher for those who are frail than those who are not. So screening for frailty may be a useful tool as well. in our program, we use the clinical frailty scale, not necessarily always as a screening tool, but as something to give us an indication of the general patient population coming through. And we generally try to direct our colleagues to refer patients to us who are probably somewhere between 3 and 6 or 3 and 7. Although on occasion we get some who are very fit but have other indications for prehab, or those who are very ill, who are actually already admitted to hospital, who may require prehab simply to become a surgical candidate. A nice paper by Tu and colleagues provides some guidance in terms of who is ideal. They've simplified it very nicely here by saying if the person is going through a major or complex surgery, has low physical activity, or is suffering for a poorly controlled chronic health condition, I would include frailty in this mix. They probably are good candidates for prehabilitation. So this is a useful reference to take note of as you're thinking about who may or may not be most applicable to your prehab program. So after we've identified the right people, how do we assess? Well, as I mentioned, the cardiopulmonary exercise test to derive VO2 gives a really robust understanding of one's surgical risk. When we're thinking of particular thresholds, generally speaking, a VO2 of less than 15 mils of O2 per kg per minute puts a person in a high risk category. And if we're looking at anaerobic threshold, because a client necessarily can't necessarily meet max or P criteria, less than 11 mils of O2 per kg per minute would be considered someone at high risk. I would direct you to Denny Levitt's work, and in particular this consensus guidelines paper in the British Journal of Anesthesia that really extensively goes through the relationship of CPET and related outcomes associated with surgery. But CPET, as I mentioned previously, does come at a cost. It is highly resource intensive from an infrastructure and personnel standpoint, and thus contributes to significant costs for a program. So the alternative, as we described previously, is a 6-minute walk test. We just said previously the 400-meter threshold is a good consideration as a screen, but it's also important to know what the minimal clinically important difference is. And in prehab literature is somewhere between 20 and 50 meters. And what that means is that if you've made an increase, or if you've contributed to an increase of about 20 to 50 meters in a 6-minute walk test, you're likely to have other meaningful outputs in terms of quality of life or functional status. So it's a robust measure of both risk, but also efficacy of your program. So just to recap here, who are some prime candidates for prehab? Low PA, low functional capacity, low aerobic fitness, or someone who's frail. And while I put these up here as some prime candidates, I'd highlight that there are many other important indications for prehab. And certainly in our program, we see patients who are deconditioning over the course of the preoperative period, who are psychologically distressed, or who are just really worried about their overall experience in ways which prehab gives them a bit of control. And if they are frail, it's important to consider other mechanisms by which we can understand the patient's overall well-being. And for those who are familiar, the comprehensive geriatric assessment is a great tool. And as you might expect, it includes the element of functional capacity. So a quick summary of some things here to consider. If you're assessing a patient for prehab, there are some self-reported tools, again, physical activity volume or functional status by the Duke Activity Status Index. These are some common ones that we like to use. Body composition, again, very standard, BMI, waist circumference, body fat percentage. If you're dealing with a patient who's been diagnosed with advanced cancer, stage 4 cancer, potentially you may want to get an indication of any metastatic lesions across the body that may change your ability to exercise in those areas. It's important to get some details about those lesions as well in terms of their size and their type and so on. From an aerobic standpoint, we've been discussing the CPET, the 6-minute walk test, but other measures like the 5x sit-to-stand and the 30-second stand test are still good as measures of both pre and post fitness to indicate any change. Musculoskeletal wise, we use the grip strength, but again, additional measures that you might find in your clinic would be useful. But I think it's also it's also important to highlight some other maybe more nuanced measures of function. And so, for example, in head and neck cancer, I think we may think of things like speech or swallow function or shoulder and neck range of motion as things that are likely to change as a result of the surgery. And if you have a good understanding of where they are at baseline, it gives rehab professionals a better target for outcomes after surgery. And while that's a good example for head and neck, there may be different scenarios like in breast cancer, where shoulder, chest, back, and core strength would be important to understand, again, as targets for post-op rehab. So in terms of our intervention, what are some considerations that that we should know about how to deliver prehab? Well, I'll go through all of these in a little bit of detail, but again, really what it comes down to is knowing the patient, individualizing the program, and understanding what's next for them. So first and foremost, I know this is probably obvious to many, but you should know what type of cancer the patient has. And understanding that will then give you a good understanding, likely what they may be going through in terms of their treatment. And what is relevant about this, especially for those who are about to undergo surgery, is that many people with cancer may have neoadjuvant treatments. And these may change a lot of different elements of physiology. They may be local to a particular area, or they may be more systemic, like cardiotoxic effects. And so understanding what they're going through or what they may be, what they may have recently completed will be important for determining how you create an appropriate exercise prescription. You should also understand, obviously, what you're prehabilitating for. Is their next treatment indeed surgery, or is it radiation? And, you know, again, for many different cancers, you may have very many different sequences of treatments. So you do need to know the pathway that these patients are going through in terms of their treatment process. Can you expect anything after surgery, for example? Are there adjuvant treatments like radiation therapy that may interfere with the recovery that you may also want to prepare for in the pre-op period? Or can you multi-phase your prehabilitation in ways that helps you focus on surgery in phase 1 and then perhaps on radiation in phase 2? Of course, any other medical considerations that may influence their ability to prehab? And then a good understanding of their expected date of their next treatment, or what your time frame is for prehabilitating, is important. And I think, you know, it's worthwhile considering that for many patients, prehabilitation may only last for a few weeks or perhaps a few months. You know, there's a few stats here, and I won't belabor some of the details in this, but for many of the patients, we may have prehabilitation windows of only 1 or 2 weeks, whereas in some others, we may have 4 to 6 to 8 weeks. So the prehabilitation window really guides us in terms of what we can invest in. And sometimes we can't expect to have much time to work on patients via exercise, but rather focus on education and try to make gains in their adherence and understanding of their rehabilitation, so that that is where maybe they get their bang for their buck from a prehab standpoint, is in that education on rehab. And as you understand the time frame, it's important to think about what that surgical pathway is. And this is a map that we've done for our program development, and just want to highlight a few things. We really want to minimize the time from diagnosis to the initiation of prehab. And when you minimize that time, ultimately what you're doing is you're maximizing the prehab duration and giving prehab the opportunity to do what it's good at doing, which is creating that physiologic buffer. And these complement and kind of overlap a little bit with a concept called early recovery after surgery protocols, which sometimes start in the day of surgery, just before surgery, and can last in the acute perioperative period. And some ask, you know, why would we consider prehab programming in the postoperative space? Well, in general, what we do in our program is we don't necessarily rehabilitate patients after surgery, but after spending this much time with a person prior to surgery, we have a really good sense of their baseline function. And we can get a picture of whether or not they're doing well after surgery if we conduct another assessment in that post-op period. And if we find that they're really struggling with some of their surgical outcomes, we may refer them to rehabilitation in a more expedited way than they may otherwise have if they went through the usual route of their clinic appointments with their surgeon. So in this particular slide, we have 30 days post-discharge. We recently moved that to 45 days post-discharge based on some great advice from our physiatry colleagues, because sometimes at 30 days, people are still just recovering from surgery. Okay, so individualization. I think any exercise prescription needs to be individualized, so I'll start with that key point. In prehab, it's no different, but there are a few things probably that are worth discussing to make sure that you've got a really good framework for how you want to go by exercising, how you want to go about preparing an exercise program for someone. I think first and foremost, intervention terminology is important. I think physical activity is great all the time, but in a prehab setting, I think we're really talking about this really intention, structured, repetitive exercise that really has a goal of maximizing fitness gains prior to a stressor. So we're not necessarily trying to just go about increasing physical activity volume, although we are happy to have that going on as well. We are really focused on exercising the person. And in terms of exercise, we may break that definition down a little bit further as well. In terms of conditioning-based exercises, where we're focused on global wellness and physical fitness, as well as potentially incorporating some impairment-based exercises that address some of the local regional dysfunction disability that people may experience as a result of their treatment. So multimodal prehabilitation, again, I'll focus on the exercise pieces here. And, when I'm thinking about an approach to prehab, I think it's useful to consider someone who's injured a part of their body. And let's use this little figure here to describe maybe what may happen if one injured their ankle and they need to go through some treatment for that. Well, I think, it's important not necessarily just to, well, I'll start off with it's important, I'll start off focused on the actual affected joint or region. If it's going to be potentially damaged through surgery, then I think we need to consider some of the very local tissues that are adjacent to the injury and make sure they are healthy to withstand some of that surgical trauma and recover quicker. But in addition to those local tissues, we also want to think about other maybe regional or organ-specific training that may relate to the overall recovery period. So while this individual has had an injured ankle, and yes, those tissues are going to be affected, they may need walking aids, or they may need stronger upper body so that they can lift themselves out of bed, or they may need to learn how to balance themselves using different supports. So it's not necessarily just the local tissues that we want to prehabilitate. It's probably those other parts of the body who are going to have to bear the brunt of the recovery process. Now, when we think a little bit more systemically, yes, they may have injured their right leg, but again, where's the weight going to be supported from over the course of the rehabilitation period? Likely on their contralateral leg. So making sure they've got a strong opposite leg is going to be important. Again, as I mentioned, preparing for assistive devices. Overall cardiorespiratory conditioning becomes very important because they're likely to be bedridden for at least a little while. And then how do we improve patients' overall well-being north of the shoulders? And I think, as I mentioned previously, empowering a patient to be active in the preoperative space gives them some control over their overall outcomes. And, just to think about, why it's important to think about those local regional spaces and think very broadly about a particular treatment. Just look at this list of affected tissues associated with breast cancer surgery and reconstruction. We're talking about from a tumor resection alone, especially if it's a mastectomy, the pecs, the trapezius, the deltoid, the rotator cuff, the serratus anterior, and others are going to be affected by the tumor resection specifically. And then if someone undergoes reconstruction, depending on the type, you're going to have abdominal surgery, you may have lats involved, oblique, serratus, glutes, or the gracilis. And so all of these tissues will have some surgical traumas that likely could benefit from either a focused prehab program on that space or the contralateral tissues that will have to support the patient after that surgery. So hopefully I've made the point that really thinking about the surgery is important to guide the types of exercises you do. I also want to highlight this idea of a maximal tolerable dose. And because we sometimes only have a very small window of time, high intensity interval training, which has shown to provide greater gains in aerobic fitness over a short period, is something that prehabilitation literature has generally gravitated towards. And so for a lot of the studies that we've done, as well as more broadly speaking across the prehab literature, HIIT is a common aerobic modality. And if you're worried about whether or not HIIT is safe, it is highly safe when it's done in a supervised manner with people who are qualified. And this is a good example of one in a patient population of 151 people with lung cancer, about 21 days of prehab, and they found that their HIIT protocol increased VO2 peak and functional walking capacity in that period of time. and patients had low post-operative morbidity. So again, this is a good example of a high-intensity aerobic protocol in a fairly vulnerable population. If we're thinking about other prehabilitative modalities that are maybe a little bit more local regional to the abdomen and thorax, inspiratory muscle prehabilitation has gained a lot of interest over the last little while. This is really working on diaphragmatic strength, and it's shown to improve pre-op inspiratory pressure, reduce pulmonary complication rates, and reduce length of stay. So this is not even a global type of conditioning. This is really just inspiratory muscle training using a small device with which patients just suck in as hard as they can against the pressure to strengthen their inspiratory muscles. And the evidence quality is moderate to good, actually, and something that we've implemented in our program. In terms of radical prostatectomy and the potential for preoperative pelvic floor muscle exercises, there's a bit of conflicting data in the meta-analyses. So it's hard to make a strong recommendation for this, although we do try to consider as a part of our teaching for the postoperative space, but as well as an understanding of the potential effects it may have preoperatively. So we do it in our program. In terms of pelvic floor muscle exercises for pelvic organ prolapse, the evidence seems to not be quite as good there. So no benefit on that side at least as it pertains to the available data to date. So we're wrapping up in just a few moments here, but some other considerations as we're thinking about how to prescribe exercise. From a dietary standpoint, we are very fortunate to be supported by a fantastic dietetic crew who really help us make patients as healthy as they can be from a dietary standpoint. So we really focus on avoiding malnutrition, promoting anabolism, and often this may require some supplementation. This is very particular to the individual. So there is a thorough dietetic assessment that goes on before we would simply supplement a patient. And then, of course, there's behavior change. I'm sure that will be a component of this week's chats. But we do need to think about what people are willing to do for exercise and what barriers or preferences they may have for it. And if there are barriers, how do we minimize them? And while it's great to have a small window of time to work with a participant and really have that motivating characteristic that surgery can sometimes bring, we would love to see the benefits of exercise and health behaviors that are initiated in this preoperative time continued well after surgery and hopefully become a part of someone's lifelong well-being plan. Other areas of behavior change that are being investigated include sleep hygiene, and smoking cessation and other substance abuse cessation programs are actually a very, very important part of many preoperative programs. And in fact, for those who do smoke, probably the one thing you can do to improve your surgical outcomes, if you could only choose one, I would say is absolutely stop smoking. Okay. So on the other side of surgery, what is it worthwhile knowing about? Because now that you've had a great picture of a person as they get ready for surgery, how can you help them in that post-op period? Well, it's good to know what the indications are for rehab. So if you do see them after surgery, you can identify an issue soon and refer them to the appropriate health professional after surgery. It's good to know the timeline and when to expect a potential adverse event. We know that some adverse events happen immediately after surgery. Some take a little while to manifest. So keeping an eye on those is important. Knowing how to get to those rehab professionals and hopefully having a list of them is great. And then what that composition of rehab is. So for example, are they working on specific exercises? If they are, could you introduce them preoperatively to help them stick a bit better? And the question I often get is who typically prescribes and delivers prehab exercise? Well, I think all clinicians can endorse the physical activity guidelines of 150 minutes per week and 2 days per week of specific resistance training. When we're talking about conditioning-based exercises for clinical populations, kinesiologists and certified exercise physiologists are often the ones who are delivering this. And in some scenarios, personal trainers are doing it, but often under the guidance of KINs or CEPs. And if impairment-based exercises are a part of the prehab plan, then these can often be guided by a physiatrist or a physiotherapist and supported by KINs or CEPs. Now, again, I'm sure someone is going to get upset, because they're not listed here. But there are many, many exceptions, and they're relative to the training and qualifications and experiences. And I know fantastic personal trainers who deliver prehab programs, fantastic occupational therapists who do them. And so really there are exceptions, but this is generally what's represented in the literature and amongst most programs. And overall, really it is an interprofessional approach. I think that, you know, the qualified exercise professional, as I define it, is someone who could be a physiotherapist, a kinesiologist, or a CEP. And really it's about maximizing your scope of practice without going beyond it, and then complementing it with those who work in that space similarly, or those who have different skill sets or scopes. So really, I think, you know, you have to think about the entire team and who can help you get a patient as fit as possible for surgery. And I'll leave you with a few resources in case they become helpful as you think about prehabilitating your clients. These are two that have come out in the last few years out of the UK. On the left, we have a Macmillan guidance document on prehabilitation for people with cancer. This is a very friendly document to both patients and healthcare professionals. On the right, we have a little bit more of an advanced resource specific to the perioperative assessment in adult surgery. This includes consideration of COVID-19 related factors. So these together provide a really nice description of what prehab is in cancer and more broadly in other surgeries. At the end of the day, I think some essential points to take away from these resources is that it's important to find the right group to invest your time in. Prehab can start ASAP, including at the time of a positive screen. Know the patient so that you can provide individualized prehab, and that it's not necessarily just for surgery. And if you're looking for any more reading material, just last week in Current Anesthesiology Reports, we published a paper titled Introduction to Preoperative Exercise Prescription and Physical Activity Promotion for Clinicians and Exercise Professionals. So given the focus of this week's activities, this may be a relevant paper for you to consider as you consider prehab. Won't spend any more time on too many more slides here, other than if you're thinking about developing a prehab service in your clinic, some work by Andrew Bates, Malcolm West, and Sandy Jack, as well as others here on this slide, provide some really smart insights to getting towards a prehab program in your program. And I know I've spoken probably over time here, but I really appreciate everyone's attention today. And certainly if you have any questions, feel free to email me or reach out in any way you can. Thank you so much again to Dr. Nicole Koulos-Reed and her team for having me. I'm happy to chat about prehab if you have any questions. Thanks.